for making today's event and other events this year possible. We view these events as an extension of the journalism that we produce in our daily email newsletter, and they would not be possible without the generous support of our sponsors. So a huge thank you to Anthem Blue Cross and Blue Shield of Wisconsin, Deloitte, Froedtert and the Medical College of Wisconsin, Husch Blackwell, Mayo Clinic Health System, Briesen Roper, and the Wisconsin Hospital Association. Thank you also to Badger Bay Management for hosting today's virtual event in partnership with Wisconsin Health News. Wisconsin Health News is an online, nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial. You can do so in the event evaluation survey, which we will email out after today's event, or you can also sign up on our website at wisconsinhealthnews.com. And I want to give an extra thanks today to Husch Blackwell, who is today's featured sponsor. Husch Blackwell has been a very generous supporter of Wisconsin Health News, and we are very grateful for all of their support. Here to say a few words is Jed Roher, a partner in the firm.
Thank you, Tim, and good afternoon. As Tim said, my name is Jed Roher, and I'm a partner in the Madison office of Husch Blackwell. We're delighted to be a sponsor of Wisconsin Health News and the Newsmaker series, and I'm honored to have the opportunity to spend just a few minutes with you all today. Husch Blackwell has over 700 lawyers in 19 offices concentrated in the middle two-thirds of the country, and just about 1/6 of our lawyers are in our Madison and Milwaukee offices. We have one of the largest healthcare practices in the country, with over 130 lawyers focusing their practices within the healthcare, life sciences, and education industries. While Husch Blackwell is relatively new to Wisconsin, opening its first offices here in 2016, our Wisconsin lawyers are deeply rooted here, and many of us, myself, Tom Shorter, Bruce Arnold, Kate Betchin, Pat Coffey, John Anderson, Wendy Ahrens, Tom O'Day, and Tom Godar, to name a few, have had the pleasure and privilege of working with many of you over the years, and we look forward to continuing to do so. For those of you who haven't worked with us or don't know Husch Blackwell and our team, our approach is to organize our attorneys within industry groups, allowing us to collaborate across disciplines while we remain ever attuned to the unique dynamics, challenges, and opportunities within healthcare. We work with health systems, provider groups, insurers, and emerging health technology companies with respect to a broad range of legal matters, including regulatory matters, transactions, labor and employment, data privacy, intellectual property, and the like, allowing us to see the industry through many different perspectives. We look forward to continuing to collaborate with all of you working in Wisconsin's strong and dynamic healthcare industry. As always, Tim and the Wisconsin Health News team have done a fantastic job organizing a compelling presentation today, and I, for one, am very much looking forward to hearing from our esteemed panelists. So without further ado, I'll wish that you and yours stay safe and healthy. I'll thank you again for joining us today, and I'll turn things back over to Tim.
Great. Thanks so much, Jed. And thanks again to Husch Blackwell for your generous support. And thanks again to our esteemed panelists for being here today. At last year's hospital CEO Roundtable, coronavirus was not a word in most of our vocabularies. During the past 7 months, it has dominated the thoughts of these 4 leaders as it has our daily lives. The way that healthcare is delivered in our state has undergone drastic changes as we continue to respond to this unprecedented pandemic. And some of these changes could be here to stay when the pandemic finally, hopefully, fades to the background. For now, though, the COVID-19 crisis remains front and center as cases surge across the state. Only Texas and California are recording more daily COVID-19 cases than Wisconsin right now, and their populations are 5 to 6 times greater. Over the last month, hospitalizations have nearly tripled, setting yet another record Monday with 950 patients in Wisconsin hospitals for COVID-19. In certain parts of the state, we are getting close to a crisis situation as hospitals are nearing capacity and healthcare workforces are strained to their limits due to the increasing community spread. This week, the Surge facility on the state fairgrounds is opening its door to patients, making Wisconsin one of the only states in the country to get to this point. So we absolutely have a lot to talk about, and I want to get right to it. Chris, let's start with you. So what happened? How did things get to this point here in Wisconsin?
Well, we did really well initially with the flatten the curve objective and people staying home under the stay-at-home order. And as that was lifted and summer holidays happened and people started to loosen up and go to weddings, for example, and go and gather socially and attend events. And the masking started to wear off and people There are people who subscribe to it and believe in its effectiveness, which I, by the way, do, and others that don't. And so we see all of these dynamics happening. And as of Labor Day, at least in northeastern Wisconsin, we saw the peak coming again at us. And we saw positivity rates in testing go up. And we always know that that translates into hospitalizations. So we saw it coming, and we began once again in our community sharing information among the healthcare systems and talking with each other about our hospitalizations and how we would manage our capacity and our staffing, to be quite honest with you, because I think what people don't realize is that just as the positivity rate is increasing in the community, that has an effect on our workforce, and our workforce ends up being exposed in the community to COVID-19 and then ends up in quarantine or isolation and unable to fulfill their job responsibilities for that period of time. And that makes it extra challenging on us to manage this increasing capacity that's coming at us. So it's a whole host of things. And the word fatigue has been used about the virus and sort of that, we just get a little bit lackadaisical about some things. And I think that's some of what is going on in our community, at least.
Thanks, Chris. So where are things right now with Bellin in terms of your hospital capacity? About how many COVID-19 patients do you have, and how does that compare to a week ago, to a month ago?
So today we have 30 COVID patients in our hospital, and a month ago we would have had 10 or 12, and a couple of weeks ago we would have had in the 20s, and now we're up. We've been up in the 30s for the last week or so. Last week we were red as a status for our system, and that takes into account both the capacity from a COVID standpoint, but also just our overall capacity. We still need to be able to take care of the whole community. Heart attacks are still going to happen. People are still going to have babies. Strokes are still going to happen, and people need to be able to access our services for all of those things. When you look at our overall capacity last week, we were approaching the 100% of our capacity, even with some of our surge protocols in place. Now this week, we're in the orange, and part of that is because we brought online additional beds in one of the facilities that's on our campus that we got approval to open up as hospital beds, and that has helped us.
Thanks, Chris. What are some of the other steps that you've had to take or is on that radar that could be taken to respond to this increase in hospitalizations?
So from a staffing standpoint, we've done a lot of things. We have an amazing team, and they've been really nimble and willing to learn new skills. Everyone from athletic trainers and people who teach fitness classes are raising their hand and saying, what can I do and how can I help? And any amount of pressure that they can take off of our frontline staff is great and very, very helpful. So we've done some of that. We've brought in agency nurses. That's something that we hadn't done in my 20 years at Bellin for hospital services. And so that was new for us, but it was a necessity. And again, part of it is because we're seeing staff that are having to be quarantined, and it's impacting some of our smaller teams. So we've done that. We've also paid really close attention to the alternate care facility that's opening in West Allis and understanding what it can offer to us and how and when we might face the need to look that way and use that service. And so we've been participating in those calls just to learn as much as we can about it and to start to think about what would be the trigger that would cause us to say, hey, we're going to need some help here. Obviously, we wish that it was closer. It's very difficult for us to consider sending our patients all the way down to West Allis for care. So it will be out of an extreme sense of necessity before we would do that. But we are keeping our eye on that.
Thanks, Chris. So to follow up on that, a spokesperson for Bellin told Fox 11 in Green Bay last week that there were plans, at least talks about a local surge facility closer to home for your patients. Is that still the case? Can you share any more about what a potential local facility could look like and what that would mean?
Sure, Tim. So that's the facility that I was referring to earlier that it's on our campus. It used to be a nursing home. It since had shut down, and we purchased that building, and it was sitting basically empty. We were using it for some ancillary services and to run our testing facility out of. And we since have converted that space into hospital space so that it could be used not for our COVID patients, and it's not a nursing home, but it would be a transitional space for some of our lower acuity patients while they get ready to be discharged home. So just freeing up some capacity in our hospital building.
Great. And is this something that would be a community facility, or is this more focused for Bellin patients? And then maybe part B of that question, can you also just talk about the follow up with what you said earlier, the communication that's been having so far with area health systems and those discussions about what happens as the area reaches these capacity levels?
Sure. Yeah, we've had great collaboration between the three systems that exist here in Green Bay and in this Northeast Wisconsin area. Our CEO discussions happen every single day. We talk about what our internal capacity is. We've helped each other run testing sites. We've done a lot with just how protocols and how we're more effectively handling patients in our emergency department and the transitions to home, for example. And as far as the surge facility, absolutely, if we have capacity and we can help in the region, we're open to accept transfers from other facilities as well. But again, we all look at the same numbers, and right now, all three of us are seeing our numbers on the high end, and we're all talking about it and thinking about how we might manage that better together.
And as you mentioned too, a lot of this comes down to workforce. A lot of the determination for the capacity you have is how much workforce you have to care for these patients. And as you talked about, this is really being impacted by that increasing community spread. Can you talk a little bit about what the status is at Bellin right now in terms of your workforce and how that's been impacted?
Sure. We've had anywhere from 150 to 225 people on quarantine. Not all of those are hospital workers. Some of those are from our clinics. So we look at it across our entire system. Today, I think we have 142 that are in quarantine. And some of those end up being our doctors as well. So we had two of our hospitalists at one time that were out on quarantine because of an exposure that they had outside of the workplace. And when that happens, we have to go and tap other resources. Thankfully, we have some primary care physicians that are internal medicine trained, and they have been really wonderful about saying, we'll come in and help, knowing that that's where the greatest need is, but then that impacts their practice, and their partners then have to help take care of the patients that are on the schedule that day in the clinic for those clinicians. So it's really been a team sport, and I'm very fortunate to have the team that I have, and everyone is saying, what can I do and how can I help? And I don't know what we would do without that team spirit.
What more can policymakers do specifically around this workforce issue?
Well, it's been very helpful to have the licensing issue addressed and loosened up a bit. And, I think more of that and more of looking at how they can help us with that. I think that, we've looked at our students at Bellin College and how can our students help us? And can we look at ways from a policy standpoint that we can help students get through their boards faster and get online faster to be able to help us? All of those things are very, very helpful. And we appreciate everything that WHA has done in promoting that on our behalf and really listening to what we need and bringing that forth to the policymakers in real time very quickly and getting those addressed. It's been very, very helpful.
Thanks, Chris. So I am going to leave you for now, but we will come back to you. And I want to move on to Damond. Damond, where are things right now at SSM? Dane County set another record yesterday for hospitalizations. Are these all Dane County residents filling the hospitals? Is it patients from other parts of the state? What's kind of the status at your facilities right now?
Well, thank you, Tim. And let me first say, Chris was on a roll. I would just enjoy listening to her, by the way. And let me also just thank you, Tim. You're sort of our modern day Tim Russert of Meet the Press, by the way. So it's always good. Glad to have you pulling this group together. And for those that are listening and watching, I also have to make this small little plug. It's really my joy to spend time with both Chris Woleske as well as Cathy Jacobson and John Russell. If you don't know them, they are three outstanding leaders in healthcare, and we're all in good hands to have people like that committed to the healthcare profession. So I want to say that first and foremost. Specifically to your question, so it is rising. That's the trend that you're going to hear, Tim, probably all day if you ask any one of us. It's rising here as well. We have SSM across Wisconsin, 7 hospitals, 85 clinics, and 10 nursing homes. And as I stand here today, we have 60 patients that are in-house in various locations. That's the highest number it's been since we've started. If that number last week was probably 40, I guess, and so it's been rising pretty rapidly. We are cautiously looking at those numbers on a daily basis, looking at our capacity, looking at our vent use, looking at our PPE as well, right? And so we're looking at all of those different factors, and we're coordinating our efforts with our other sister hospitals. They're not on the call today, but I do want to give a shout out to both Meritor, Sue Erickson, as well as Alan Kaplan from UW Health. So similar to Bellin, we're doing the same thing here in Dane County, where we're all sort of working collaboratively together to sort of work through this particular crisis.
Thanks, Damon. How are things in terms of you mentioned this increase in hospitalizations? How are things in terms of your capacity and also your workforce? How is your workforce going as community spread does increase in the area?
Yep. And then let me get to, I think that second part of your question. So it's a mix. So right now we probably have maybe half of those patients that are COVID positive coming from within Dane County, and then the other half coming outside of Dane County, contiguous counties of Dane. So it's sort of a 50-50 mix of the patients who are coming in. How are we doing, I guess, in terms of our workforce? That's my number one concern. At the end of the day is sort of workforce fatigue and workforce stress. We've been doing this now for 6-7 months. We've asked a lot for our healthcare professions to be professionals, to be right at the front line, the spear's tip of this pandemic. And there was a lot of worry and concern in the very beginning because no one, again, wanted to sort of contract COVID itself. But as we've had some time to manage through this, have the appropriate PPE, and that's personal protective equipment. And probably like Cathy, like John, like Chris, I want to thank a lot of the manufacturers right here in Wisconsin that stepped up, and other businesses, quite frankly, that stepped up and produced a lot of the gowns and masks and gloves for us when we really needed them. But that's helped. So that helped ease a little bit of the anxiety because we know we at least have the PPE available to maybe get through the next surge or two. But the stress of everything related to COVID still exists. And that's what's weighing down on our workforce right now. And some of them are calling out sick themselves. Now, the good news is, even though the positivity rate in Wisconsin, although it fluctuates, between 9 and 12% on some days, for our workforce, it's under 2%. And many of those, 95% of those, quite frankly, have happened outside of the workforce. So outside the workplace where they've contracted corona. So dealing with quarantine, dealing with those that are patients under investigation, dealing with staff that are actually sick, maybe not COVID, but maybe with other things, but continuing to having to work and take care of those patients who are really in critical need. That's probably my number one concern. And so we're trying to come up with several different strategies to try to minimize that as best we can.
And how are things in terms of capacity right now, specifically at St. Mary's in Madison?
So of our hospitals, and we have a blend of hospitals that are in urban settings, and we have hospitals that are in rural settings. I think the ones in Madison, Dane County specifically, and St. Mary's, they are higher in capacity, particularly related to their ICUs, Tim, right now, and their step-down units than some of our other hospitals. And the other hospitals have a little bit more capacity just yet, but we are developing a plan that's going to utilize all of our beds, no matter where they're located in the state itself. And so that we can sort of save, if you will, many of the ICU beds as best we can for those COVID patients and those critical care patients, and fill up those less critical patients in whatever setting we have available to them.
Great. And can you talk a little bit more about plans in place to address workforce issues? If that becomes more of an issue, for example, do you anticipate calling in SSM workers from other states? What type of conversations are having right now around that?
Well, now I don't want to give up all my secrets because I know Chris and Cathy and John and company, you know,
it's just you and me talking right now. It's just
that's right. So we're pulling out every stop. I mean, by the way, so I will say first, it is helpful. The recent sort of order that came out that provides for interstate reciprocity of medical licensing. It's something that our own association, Wisconsin Hospital Association, has been an advocate for quite some time. So that does help us sort of bring back recently retired doctors and nurses and other critical staff to give us a little bit more flexibility. We are enhancing our regional float pool. Float pool is basically the concept that no matter where you might be home based, there may be times and circumstances where you're allowed to, we call it float or go to other facilities that are within, you know, a 30 to 45 mile radius in order to fill a particular need. We're doing a lot of cross training, Tim. Again, everybody I'm sure is doing this as well, but we're doing a lot of cross training of staff so they're more confident working in multiple departments and multiple settings. We're trying to provide whatever incentives we can, both to not just retain the staff that we have, but have them work during multiple times and days and shifts, but also bring in contract agency if necessary to fill certain gaps. But Tim, I also want to mention this too. So that's what we're doing just in terms of the resource itself sort of being available at the bedside. But I do not want this point lost at all. The other thing that I realize as I personally go out to visit hospitals and clinics in the various settings that we have, I see the emotional fatigue that's in their eyes, that's on their faces because of the work that they're doing. And although it's very commendable, I'm concerned because you have to wonder, how long can that last? You know, how long can this really go on? So the other piece to this is providing resources for those that are right there on the ground and saying that we have to take care of you emotionally as well, right? We got to take care of you physically as well. And so we have what we call employee assistance program. There's usually a stigma around employee assistance program, but I want everybody viewing this to know right now that I too, as the regional president SSM, I'm using my very own employee assistance program for de-stressing activities and other methods to help provide balance, right, in the workplace. So we provide that kind of assistance to our workforce. We have small groups in virtual settings where we come together and sort of talk about how our day is going, what problems exist, how can we solve through those problems. We call it kitchen chats through a virtual platform, which has been very powerful for our employees, as well as have support groups as well. So I don't want you to just think it's about the physical aspect of just hiring somebody for a position. It's also about the emotional aspect, and we're trying to do both sides of the coin.
Thanks. One more question for you, Damond, and then we'll move on to Cathy. But Damond, Department of Health Services Secretary Designee Andrea Palm said last week that the alternate care facility at the Alliant Energy Center in Madison is not, quote, flip switch ready, like the one in West Dallas, which is slated to open this week. She said the department is in contact with area health system leaders. I assume that SSM is one of those health system leaders. Can you talk a little bit about what those discussions have revolved around so far and how likely it is that this second alternate care facility at the Alliant Center could be needed? What would it take to set it up, and how likely it is it that you think it could be used?
So we are in discussions at the state level and in local municipalities around whether or not an ACF, alternative care facility, is needed. We are sort of trying to take a part of the playbook from Milwaukee, and I'm sure Cathy, who's up next, can talk exhaustively about this, to learn from their lessons that was applied to their particular setting to determine the actual need for an ACF. I will say, to the credit of many of the facilities that are in South Central Wisconsin, John Hospital included, John Russell, Prairie Ridge, is that a lot of us have put in place some really solid surge plans, we call it. A surge plan is basically taking up our capacity past its sort of license capability or staff capabilities in the worst case scenario as contingency planning, so that we can see more patients. And sometimes you have to be very, very innovative and creative about doing that. We did the same for our hospitals as well. So depending on the hospital and the size, we could go from 150% up to 175% of added capacity than what we have right now. And so between my facilities and those other facilities that are in the area, right now, Tim, we feel pretty confident that we can get through this surge. Now, if it continues and it gets out of hand and we're overrun on ICU as well as med-surg bed capacity, then that's when the ACF really comes into play, where we would need other facilities. But again, I would say not just utilizing our own facilities, but all of Wisconsin's bed capacity, whether it's urban or rural. We'd want to try to maximize and optimize first before we get there. And then, Tim, let me say one last thing. I'll let you turn it over to Cathy, because once you get to Cathy, the IQ from the previous speaker to her will go up exponentially. But let me just say this. For policymakers, anybody listening, I also want to say this. Let's not panic, and let's not over politicize the situation. Let's not panic. Let's not over politicize the situation. We as Americans, and particularly as Wisconsin, we've been Wisconsin strong this whole entire time. And we're one Wisconsin at the end of the day. And the collaboration between private, public, and governmental, getting in the same room, getting on the same page, and doing what's best for Wisconsin always seems to work for us. And so my only reminder to everybody is, let's not forget that. Even those of us that make mistakes, and I make my own set of mistakes, let's not ascribe bad intentions to those. Let's try to help one another, support one another, get through this pandemic so we can get back to the quality of life that we've all enjoyed for so long.
Thanks, Damond. It's a good message. So we will come back to you. We're going to go to Cathy right now. And Cathy, I want to talk a little bit about the alternate care facility in West Dallas in the Milwaukee area, which is scheduled to open this week. How much do you expect that to be used, and what type of involvement have the area health systems had in setting that up?
We did set it up. So I guess you could say so back, in April, when all of the leaders, the municipal leaders came together, Mayor of Milwaukee, some of the Milwaukee County folks and everything, and called the health systems on the phone and basically said, we think we need to do this. You guys are going to go figure this out for us, right? And literally that's how it happened. I would give huge kudos to the retired Ascension executives who came back voluntarily to help us lead this. Deb Standridge, the CEO, Tim Richmond, who's the COO over there. Those guys did an amazing job pulling that alternative care facility together very, very quickly early on in this pandemic. We all volunteered bits and pieces of it. All of us health systems have, whether it's transportation, the EHR, people to help stand up human resources, all of those types of things. And then we didn't need it, back in the spring. Now the call has made to open it up again. I think Deb said she needed 7 to 10 days, and she's going to be ready to go on Wednesday. So again, kudos, stood it up, kind of mothballed it, brought it right back up again. As we look at it, and Chris alluded to this, and they've said this very clearly on the news, this is not a hospital. You do not admit COVID patients to this facility. What it's used for is, can you transition COVID patients who are sitting in your hospital beds? And can you transition them there to get them out of your acute care hospital beds sooner, so you can open those beds open and they can recover better before they can be discharged to home? So there are some pretty strict criteria on what they can handle over there with the staffing that they have, the amount of oxygen that they need on the patients, how much support these patients need. There's age limitations on the patients. We are actually actively looking at it right now. Our nurses, our nursing leaders this week are evaluating what patients we would look to transfer over there. But I would say, similar to what Chris and Damond have said, our surge plans, well, we think can take us much, much farther than where we are today. But we are also trying to continue to take care of our community and everybody who doesn't have COVID, which is still the overwhelming majority of the patients that we're taking care of. So it's really more how we manage that balance than just the surge plan and implementing the surge plan. And we would look for any available help that we have in terms of managing the capacity overall.
Great. So while cases and hospitalizations are increasing in the southeast part of the state, they're not yet increasing at quite the record levels as some other parts of the state. Why do you think that is? And where is Froedtert right now and in terms of your capacity and your workforce?
You know, it's funny. I think we're probably about 2 weeks behind the North. You know, Chris and I were together not that long ago, and we're like, well, we really hope that stays up there. But it's not. I mean, and it literally looks like it just came along, you know, about 2 weeks afterwards. So actually, I would say less than a month ago, we were as low as we've ever been, you know, throughout this entire period. We had never gone below 30 patients since our peak, and we actually got as low as 27, maybe a little short of 4 weeks ago. This morning, we're at 87. And I would say that that's accelerating. You know, I think that's the other thing you watch with COVID. We've seen these waves and mini waves kind of go since April, and they kind of slowly come up and then they come down. We've been as high as the low 60s before. This is going very fast. And when it starts to go very fast, that's when you actually have to start logging some concerns. So again, across all of Southeast Wisconsin, I looked at the numbers this morning, we're a little over 330. In our HERC region right now, we're as high as we've ever been. We've exceeded peak from the spring now, again, at the high 80s. Our surge plan can take us up to 300 easily, not easily, that's the extreme. We have to start calling the question on alternative staffing models, what we're doing with other procedures at about 120 to 150. And we have a plan for that. And we're starting to pull that plan off the shelf just to kind of dust it off and make sure that it works with where we are today in October versus where we were in May when we put that plan together, and make sure that all that's working. But that's, again, we feel, Damond said it, Chris has said it, we think we have more capacity that we can do, you know, under this. We think that we're adequately, you know, staffed to be able to do it, but we want to make sure that it's there to work. I would tell you staffing is going to be our single biggest concern. We talked about that this morning on our weekly phone call, and it's for all the reasons that Chris talked about and that Damond talked about. We've tracked our positivity rate in our staff, and for during the, what I would say maybe May and June time period, our staff positivity rates were much lower than the community even. But boy, as the summer wore on, we're below the community, but we're tracking the increase the same as the community because we have very limited exposures in our facilities, but our staff are exposed in the community just like everybody else. And it's getting up there, and then that becomes a limitation in terms of how we can staff our hospitals as we go forward. So all of those are things that we're looking at right now.
And where is the workforce right now? How much of a concern is it right now, and in terms of the level of staff that have been infected or impacted by COVID?
You know, I wouldn't say that it's an area that's limiting us right now. You know, I mean, it's you watch it, but I wouldn't say that it's constraining us in any way right now. But we do want to look and make sure as we go forward that we can move our staff and make sure they're in the areas that we need them. You know, and so we cross-trained everybody early on in the pandemic, all of those types of things. We are starting to see, are we going to have to ship some people around, you know, to make sure that they're available in the hospitals? Because again, we're full right now taking care of not just COVID. Again, out of our 870 beds, I have 90, you know, that are COVID today. That's not overwhelming us, but it's trying to take care of everybody else in our community at the same time we're taking COVID. and just making sure we have the staff in the right places. But again, you've heard it from Chris, you've heard it from Damond, we've got the flexibility to move people around, and that's really the conversations that we're having right now.
Mm-hmm. So Cathy, you've been working in Wisconsin for a while now, but before coming to Froedtert, you spent some time working in Chicago. Cases and hospitalizations are also on the rise in Chicago and Illinois, but they're not at the level right now as Wisconsin. Their statewide positivity rate, while it's not a perfect metric, it is way less than Wisconsin, as are other states. Wisconsin, as we talked about earlier, really has become the hotspot in the country. What is Illinois? What are other states doing differently than Wisconsin? Is it just luck, or how can what's to explain kind of where Wisconsin is right now?
So I can only relate, probably most closely to Illinois because I still have family, down there. They shut down. When they get to a certain positivity rate, they go back into shutdown. So for example, the region around Rockford, Illinois, which is where my family is, bars and restaurants were shutting down a couple of weeks ago because they have triggers, built into their system that say once they hit a certain positivity rate, they just automatically go to shutdown. Does that work on a regional basis? Because I know family members who just were leaving Rockford and going a county over to go to a restaurant or something like that. So whether that's effective, whether that's not, is hard to be said. But clearly there are harder limits in place, at least in Illinois, Chicago, even more so than probably the rest of the state. I can't tell you whether that's having a big effect or big difference, because again, I think it's hard to shut down regions when you can just literally drive 20 miles and be in a different region. But that's just an example of how one state's handling it differently than Wisconsin is.
Great, thanks, Cathy. So we will come back to you, but John, I've not forgotten about you. John, thanks for being here today. Can you talk about how things are in Columbus and the other communities that you serve right now? And also, what are some of the unique challenges that you face as a small hospital in dealing with this pandemic over the past 7 months?
Yeah, so I would say echo a lot of the comments from others, except for we are much smaller. We have cross-trained our team, but we have, I would say, a lot less margin for error as it relates to teammates being out, team members being out on rolling quarantines. And that can be really difficult. We haven't had a ton of positive patients in-house. We have two, one confirmed, one positive. We've been running in the 2 to 3 range for most of this time, and our team has managed that well. For us, when we talk surge plans, there's been a lot of talk about that. I think that's a really important thing to discuss. We have sort of a surge plan and we have a super surge plan. And the surge plan is something we think we can sustain for a certain period of time. And the super surge plan is entirely theoretical and depends on our team members not being quarantined. They're out in the community at times. They're doing, I think, a really good job of mostly being responsible. And we talk about that a lot. If you're out doing things that exposes you and you can't come to work, we can't fulfill our mission. And so it's really kind of personal appeals to allow us to serve our community. And I'm proud of the team. They've done a really good job. We're running 5% of our team that's quarantined at any one time. And I know that doesn't seem like a big number, but for the size of our team, that's a big deal, trying to shift people back and forth to fulfill the needs of both the COVID patients, even though we don't have that many, but also all the other patients' needs that we're meeting. And we haven't even talked about testing and tracing and all the other things that we're trying to keep up with.
Great. And how are things going from a financial standpoint for Prairie Ridge Health? A lot of hospitals were hit pretty hard in the beginning of this pandemic, even with the federal funding that they received. This has been extra hard for smaller hospitals who may not have those extra reserves as some of the larger systems. How are things going on your end? Have you started to rebound from some of those earlier losses? Kind of where are things right now?
Yeah, we lost 7.5% of our operating margin probably in 3 months. We were doing well. We're a September year end prior to that, so that helped. We're back to 95%-ish of capacity, which certainly helps. We being a small organization, we have tightened up. We haven't had the need to furlough anybody, but at the same time, we don't have team members to draw on. So we've actually, our expenses have gone up as we're trying to screen at our doors, and we're running triage lines, and we're doubling our testing capacity. We don't have the folks to do that. So we've actually hired additional team members to play those roles. So that makes your financial recovery process that much more difficult. Obviously, it's what we have to do, and we're happy to do that. But certainly, we're not back where we want to be just yet.
What type of telehealth usage have you seen? Did you see any initial increase when the pandemic started? And if so, has that changed since then? Have you started to see a dip? Is it still high? What's kind of been your experience with telehealth so far?
Yeah, we're relatively small, so we've been able to kind of track that kind of detailed. We had an exponential increase in telehealth, which I think most people would say that they did, most of the peers on the phone here. In the rural market, we've tended to see people want to come back in the building, but certainly there are within our building that some of those I could probably name quite a few of them, but I would say one that just jumps to the top of my mind is things like diabetic education. Those are folks that are, for very good reason, want to be at home. Also, understanding their home environment is extremely important to that service. And so our diabetic educators actually ask them to, hey, show me what's in your fridge. Show me what you have in your cupboards, and let's talk through things. What's your diet look like? So there's all kinds of things that we've seen that have sustained those gains. And then I would say in normal, what I would characterize as more normal clinic visits, in the rural areas, patients have largely wanted to come back into the hospital, and so we're accommodating their desires.
Great, thank you, John. So we will come back to you. I'm going to move on to Chris. Chris, you have largely been credited with coining the term coexisting with COVID-19. It's a term we have actually admittedly stolen. We use it as the title of a Wisconsin Health News event, and actually recently an event with our sister publication, Health News Illinois, as well. So thank you for coining that great term. You and I talked this summer about how important it was to maintain other services through the pandemic. We've talked about it on the webinar today. COVID-19 now, though, is fully, as you talked about, is fully in your region of the state right now. How are you now managing to coexist with it? Have you yet had to shut down any services to conserve resources? And how do you plan to manage that going forward?
So far, the coexist with COVID has gone really well for us. I think that the thinking that, healthcare is, and to steal actually from my colleague, Scott Rathgaber at Gunderson, it's a moral imperative that we provide health and access to health and well-being to everyone in the population. So that mindset is very much adopted by everyone in our organization. So as we face the increasing numbers, everyone goes into how do we make room so that we can continue to coexist with COVID. Therefore, the surge facility, for example. We also have adopted telehealth, and so much more reliance on video visits and other ways to reach out. So one of the other things you asked earlier about the policymakers and what could they also help us with, we need telehealth to stick around. So a lot more help with that and expanding broadband, because much in our geography is challenged from a broadband standpoint. And it's difficult for them to have that access to care. So really important to do that as part of coexisting. We've not had to shut down services because fortunately we have a small critical access hospital 30 miles from here. We have a ambulatory surgery center in Marinette. So we're able to use those facilities to meet the needs in a coexist with COVID kind of way. At the hospital, there have been times when we've sort of maybe slowed down some of the surgeries and, maybe push things out a day or two, but we haven't had to really restrict any of the care that we're providing. Our emergency department at times has been overrun with patients beyond their capacity. But again, the team has done amazing things by creating sort of rooms in the hallways and assigning carts and electronic health record locations to those places so that we can safely provide the care to our patients. The team comes to the aid of each other. So the coexisting with COVID for us, while challenging, it has brought out, I think, the best in our team and their commitment to our community and people's health and well-being.
So thank you. So Secretary Designee Palm said last week at on a briefing with reporters that things are going to get worse before they get better. How true do you think that is in your part of the state? I mean, the cold weather hasn't officially set in yet in northern Wisconsin or the rest of Wisconsin, which will likely drive more people indoors. The height of the flu season is upon us. What do you think is in store for your hospital and your region in the weeks and months ahead? I mean, what are you bracing for at Bellin Health?
So we're listening to what those experts are telling us, preparing for the worst and hoping for the best, trying everything that we can to communicate with our communities about what that means and why it's important to avoid that kind of a surge, having them start thinking now about the upcoming holidays and how they can maybe create new traditions and new ways of celebrating, following social distancing and masking, and just really thinking ahead and planning ahead, knowing that the respiratory season is coming and making sure that we are accommodating that in our coexist with COVID also. So really getting out there with the importance of people getting their flu shots, for example, opening up larger respiratory clinics so that we can have both COVID and other influenza-like illnesses, having a place to go to get answers to know what it is that they're facing. And working again with our colleagues around Northeast Wisconsin and the Upper Peninsula to think about how do we collectively meet the demand and work together so that we're not, sort of hoarding things or having capacity that's unused, but rather we're really collaborating to take care of people.
What would you say, and you've mentioned several of them, but what would you say are some of the biggest lessons that you've learned over the past 7 months that will be important, most important as you go forward to respond to this pandemic in these months ahead?
Communication. I don't think that internally we can communicate enough. The coronavirus is a novel virus, so it was new. And so early on, we all said, none of us are experts, and this is going to be us collectively trying to work through this. And one of the things I said to our staff early on, and I have calls with them now twice a week, I was doing it every weeknight, and I said to them, I'm going to be as transparent with you as I can. I'm going to tell you what I'm hearing and what I'm being told, and it's going to change, and it's going to change rapidly, and it's going to change multiple times. And you're going to have to be able to trust us and what we're trying to do in spite of that. And so I think being that transparent with them and acknowledging all of the changes, everything from the CDC changing things to locally the Department of Health changing things, public health having to adapt. We were all trying to do our best. And I think Damond said it before, and I couldn't agree more, believing and assuming the best in people, I think helps us get through this. Assuming the worst and being negative doesn't help. And I think that some of the lawmakers and the politicians, both at the federal level and at the state level, and the divisiveness and not assuming the best of each other and not coming together in a collaborative way hasn't helped us. And if I could ask them to do one thing, it would be to try to step in the shoes of the healthcare providers, the business owners, and the schools and the constituents, and really think about what does it mean when you're negative and you're divisive versus when you try to communicate in a really open and transparent way and truly listen to what they're asking from you. Internally, I try to listen to my staff. I try to, again, be as transparent as I can. And how we communicate with each other during this is really important. Not listening to each other is not a good option.
Thank you, Chris. Damon, I'm gonna go back to you. I understand that SSM we haven't talked a lot about testing yet today, and I know we're running out of time, but I want to talk a little bit about testing. I understand that SSM recently set up its own testing operation. Can you talk about why you did that? How many tests you're able to process, and overall your thoughts on how testing is going in the state? Are we testing enough people in the state right now?
So I'll start backwards. I don't think we're testing enough. If you look at other countries, per the CDC and Deborah Birx and others who've studied this, other countries that have been able to sort of get their arms around it a little bit quicker and sort of drop their numbers more effectively, they've been really good at testing often, and testing widely. And so, no, I don't think we're doing enough testing personally. But at SSM, all 7 of our hospitals now have sort of testing supplies and equipments for rapid testing of symptomatic patients or patients who are preparing for procedures. So we're doing pre-procedure testing now. We run nearly about 1,000 tests per day. That used to be in the summer, Tim, before we had the equipment to be able to do higher levels of testing. We're probably doing 75 tests, maybe 150 tests per day. So now we're able to do about 1,000 tests per day, which gives us a lot of flexibility, both testing our staff, testing patients, and testing others when we need it. While the state has done immense work, right? They have done. I think there's been a lot of effort and good intentions, but while they've done immense work in providing public testing via the National Guard and other various locations, we're now recognize the need that the testing demand is going up, and then coupled with asymptomatic patients when the need is there to do that. So we may have to look beyond our current plans to find ways where we continue to be flexible to add more testing.
Thanks. So you said, Damon, at a Cap Times virtual event last week that telehealth at SSM was up in the spring, like it was at a lot of systems, and then it dipped again. It's dipped since then. Why do you think that is? And was that expected? And kind of what do you see in terms of telehealth for your patients going forward? Do you expect things to get back to where they were before the pandemic, or do you expect at least somewhat of an increase going forward?
It depends on who you are. I think it depends on who you are. So if, and I hate to stereotype, but if you are sort of a younger generation, more mobile, more used to, virtual platforms, whether it's on your mobile device or other means, they've seemed to prefer having the sort of telehealth virtual kind of option available for them. My own parents, just so you know, my dad, who's 76 years old, he's not having any of it. He's like, I have to have my doctor see me, feel my bones to make sure that I'm healthy and well. Even though he has, a physician in his family and the son doing what I do, he doesn't trust us. So you have those spectrums, Tim. You have the spectrum that's there in the extreme. My hope is that telehealth continues to strengthen, becomes more used widely, and becomes the way we sort of do business, along with in-house clinic visits when it's necessary to do so. I think we need to have the option. I think we have the flexibility, and I think telehealth and telemedicine is a really great tool that allows us to do that. And then I would just echo one thing that Chris said, which is one of the ways that, again, government can help is to continue to allow for the appropriate adoption and utilization of telehealth, remove all of the barriers and the regulations that inhibited the use of telehealth. They did waivers, but to make sure that those are removed altogether. And let's make sure that we increase the incentive so there's not a disincentive to use telehealth versus in-house clinic visits.
Thanks, Damon. Cathy, I want to return to you. The way that healthcare is currently financed, a lot of providers lose money during a pandemic-like event. I know we are in the midst of a once in a multi-generation event, but what does this say about the broader way that healthcare is paid for? This could be a whole event itself, I know, but briefly, what types of changes if any, do you see coming out of this in terms of how healthcare is financed and paid for?
So I think that any of us sitting here would say it's been broken for a really long time. We all know it doesn't work. And this just pulled the bandage off and told you about all the different ways it doesn't work. There's so many services we do where we don't make a margin, and so few where we do. And when you wipe those out, and we're just decimated from this. And then you put that with the whole value equation, that what we really should be doing is using our money to manage populations and keep them well. And again, we saw a lot of that in terms of, we have a health plan. We participate in an ACO. When we had no revenue over here in the hospitals, they had no claims. And so we had margin over on the health plan side. That's a mismatch in resources, in terms of what's going on here. So I would be hopeful and optimistic that this helps us move more towards value-based and population-based reimbursement structures. I know many of us in Wisconsin have been pushing for that, are ready for that, have been participating in that wherever we can get our hands on that for a very long time, but it needs to get bigger and broader than what it is right now. And I'm hoping that the pandemic helps with that. Number two, I would say that we have to figure out how to fund public health. John touched on it a little bit in terms of contact tracing, Damond with the testing. We've done 23% of the tests in the state of Wisconsin. So I mean, we are all taking our resources from healthcare and stepping into public health activities because it doesn't have any funding. So I'm hoping that the other thing that comes out of this pandemic is we recognize the fact that we have decimated our public health spending, and that we need to put some of that back again, because otherwise we're kind of stepping in, at the last resort to be able to do that.
Thanks, Cathy. So it's possible that a more conservative-leaning Supreme Court takes up a case on the Affordable Care Act next month, potentially increasing its chances of being overturned. If the Affordable Care Act is overturned, what impact would that have on hospital care and your operations at Froedtert?
So I think everybody has to remember the ACA first and foremost was about coverage. That's what it gave us, either through Medicaid expansion or through the use of federal exchanges. So in Wisconsin, we aren't dependent on federal funding for Medicaid expansion. Maybe that might have been something that we wanted more of here, but boy, we're not dependent on it going away either. So I think that we're advantaged from that in Wisconsin because we expanded on our own, we pay for it on our own. I think anything that limits coverage is a bad thing for the healthcare system. So if we were to decline coverage further by a challenge to the ACA, that's not good for the healthcare system, whether it comes from a federal exchange, whether it's through Medicaid expansion, however you do it. Anything that takes that coverage away is not a good thing for the healthcare system.
Thanks, Cathy. John, returning to you, what impact would it have on Prairie Ridge if the ACA is overturned?
Yeah, well, I mean, the rural facilities tend to be poor. We resemble our inner city counterparts. I mean, we tend to be poor, older, less healthy. Coverage is a concern, and what follows a pandemic is probably an economic downturn. So we'll see what happens, but I think coverage is definitely a concern, and I would have a significant concern with less coverage for the state of Wisconsin.
What would you say, John, are some of the biggest lessons that you've learned in the past 7 months in responding to the pandemic? And then briefly, what types of changes do you think you've made that could outlast the pandemic?
Well, I think you heard some of the comments from the others. I think our team learned that they're really nimble and they can adjust and make this work. We've got this, we'll figure it out. And I've been really proud of the group. Things that outlast, I think there are quite a few of them, but I think we're all going to be looking at our plant and how it works with this, our pressures in our building, our filtration systems, entry into our buildings, screening capabilities, testing. Will we need testing in the future? I can't answer that, but I know we weren't very well set up to handle it when that came. Telehealth, certainly, I think the massive expansion in telehealth that we saw early on, I believe that that's here to stay and needs to be here to stay. I think that those are probably the big ones. And then I'd jump back to Cathy's comment on public health. I hope we hold on to this hard lesson that we've learned on public health. And I just want to add one more thing before we lose time here, is I want to give a shout out to the National Guard as well. They've done a tremendous service.
Thank you, John. So we are out of time, but I want to end on this one last question. And if everyone could just take maybe a sentence or two to answer it. And we'll go in reverse order. John, starting with you. What are you most optimistic about right now?
Oh, boy. I think what I just commented on, and that's, I think our team has realized that they've got this. And I know I don't want the public to feel like that's an overestimation of how serious this is, or an underestimation, excuse me, of how serious this is. I think our team has learned that they can adjust on the fly, and we can figure things out very quickly. I think as an industry, we figured that out. I think the treatments are improving. The death rates in Wisconsin still remain good, trailing indicator, kind of a morbid thing to talk about, but that's probably where the optimism comes from. Because as you said, who knows what we have coming here yet for the winter. So I don't want to be too optimistic at the moment.
Thanks. Cathy, what are you most optimistic about right now?
I'll double down on what John said. It's my team. I mean, when we've seen what these folks have gone through, what they adjusted to, the daily changes, and I did have an opportunity to round on all of, our COVID floors, even our smallest hospital when they were absolutely full. They're calm because they have this. That doesn't mean that they're not under pressure, but they feel like they can manage it. I am so proud of our staff and our physicians, what they've been through and where they are today, and the fantastic care this state continues to give our patients. That's what makes me optimistic.
Thanks, Cathy. Damond, what are you most optimistic about right now? Oh, Damond, I think you're on mute still.
Thank you, Tim. So I would say I love history and I love American history. So I would say what I'm optimistic about the most is as I look back from the beginning of our time, and particularly in the United States itself, whether it's world wars, whether it's depression, whether even 9/11, when we're faced with over mounting challenge and difficulty and obstacle, when we've come together as a people, as a group, regardless of race and religion and creed and gender, et cetera, when we've come together, good people more times than not defeat evil and defeat bad. And so in this sense, as long as we stay focused on COVID being what's bad here and not one another, I'm optimistic that we're going to be able to get through this too.
Thanks, Damond. Chris, what are you most optimistic about right now?
Wow, that's a tough act to follow. You all have some great optimism. And I would join a lot of what they said. I think that we all have developed muscle during this time. I think we've developed heart muscle in how much we care for our communities, and we're really seeing how our communities care about us as healthcare. I think we've developed a lot of brain muscle and capacity to adapt and to change on the fly, and to appreciate and understand that this isn't the last challenge that we'll face, but when we're getting through this as successfully as we are, it gives us confidence that we can get through whatever the next challenge is. And that gives me a lot of hope and optimism. And then, of course, I am optimistic there's going to be a vaccine. Early next year, we're going to have a vaccine. By summer, everybody's going to have access to the vaccine. And we'll look in our rear view mirror and have, I think, a lot of positive memories about this time that we went through COVID-19, in spite of how difficult it was, how much we learned, and the many blessings that we all received during this time.
Thank you so much, Chris. Thank you all so much for participating in today's discussion, and thank you for all that you do. Thanks to our generous sponsors for supporting today's discussion, and thanks to all of you for tuning in.
Thanks, Tim.